Healthcare Fix is a 5-part series intended to foster debate and discussion on the state of healthcare in British Columbia.
Aging demographics, record expenditures, more costly therapies and procedures. You know, it all seems about finances these days. Financial constraint is hitting every medical system in the Western world. Here to discuss more about this important topic, I'm joined by, right now, Rick Wilson is with me. Rick is Regional Director for the Group and Living Benefits Division for RBC Life Insurance in BC. Pleased to have with me Dr. Ian Cortes. He's the President of the Medical Staff for South Island Region, also a former past President of the BC Medical Association. Also, Dr. Brian Day is here, Medical Director, Cambie Surgery Centre, also Associate Professor at the UBC Faculty of Medicine. Gentlemen, thank you for taking the time here. Let me start with you, Rick. I mean, we just had 10 provincial premiers. I think every one of them, doesn't matter their political stripe, all agree that this system as it is maintained right now, as it established right now, is not sustainable financially. What's your take on that?
My take on that, I'd like to maybe broaden the discussion a little bit and talk about something in Canada where we've met a demographic challenge in the last 10 or 15 years. And a parallel I would draw to our current challenge in healthcare would be how we've dealt with the pension retirement issue. Canadians found a way to innovate their system, make adjustments to Canada Pension, introduce the private market sector and different asset classes to allow us to meet that societal demand.
You know what I always thought was peculiar about that was that at the same time, that was about 1997, and I patted the federal Liberal government with Jean Chrétien on the back. I thought that was the single best thing they did in government. They addressed the aging baby boom population and the impact that would have on Canada Pension, and then completely ignored it for healthcare, which is exactly the same argument. Ian, what's your take on that? I mean, is it sustainable today, or you feel the pressure knowing what hospitals are doing and other parts of the medical system?
Well, I think we came from a system that was, I guess, largely acute care based. Tommy Douglas wanted people to not go bankrupt because they were having a catastrophic illness. We've now evolved into a system that covers everything from your housing, should you become a little frail in your health, right through to whether you get a transplantation. And we quite frankly can't afford that full spectrum on tax dollars alone. So the challenge is, how do we bring in non-tax dollars in an equitable way?
Interesting point, though, you are making, because we always bring up the ghost of Tommy Douglas when we want to discuss any change to healthcare, and I think it's an important one. That's not what his original concept, and he's given credit as one of the real architects of this system, but that was not his original context to cover every single thing within that program.
Yeah, we've evolved from basically an insurance plan, which it was supposed to be, that covered only physician costs and expensive hospital costs, to now covering all the societal costs of illness. And it is quite a different concept than I think he had envisioned.
It's interesting, Dr. Day, when they first started in 1966, I think the per capita expenditure was about $64, and now it's close to $2,700 a person.
Yeah, actually it was about $32, so it's now close to $3,000, and I think that that's the crux of what's happened. Back then there were no there were no MRI, CT scans, transplant surgery, and so on and so on. I think it's now close to a crisis, and I think an example of that crisis was in the magazine The Economist during the last recent federal election. Actually, there was an article mocking the attitudes of the three candidates for three main candidates for prime minister, because a cartoon in The Economist showed them all pouring money into this black hole of healthcare without any ideas on how to restructure this system in a crisis. And it now is going to be forced on governments across the country, because at between 43 and 46% of the provincial budgets across the country, and the graph is heading up at least 60 degrees, something has to be done, and if it isn't done by a decision, a logical decision on the part of government, it's going to be forced on them just by economic reality.
Yeah, it's kind of interesting. Denis Desautels, the former Auditor General, back in, I think, the year 2000, said that Canadians judge the value of a program by the resources spent on it, not by the results that they've achieved. And you'd see that firsthand in a hospital, Ian, with this global budgeting. They give you a lump sum of money in a hospital, regardless of how many procedures are performed.
Yeah, it's the only place where I go to a meeting, and when they tell us that we've actually increased the amount of surgical throughput, it's looked as a bad thing.
Well, that's an important point you're making, though. That people should get this, that you're an inconvenience to a hospital because you're a cost, and there's no
Exactly.
recovery for that. And hence, that's why you might get shuffled from one hospital to another.
I think too, though, Michael, the ground shift here, and we're sort of skirting around the edges, I think we're going to see a change in how care is delivered. And let's look at the needs of a far more aged population versus the one that we would have started in 1966. And we've had some discussion ongoing, but I think one of the issues that I see showing up is a shift from not cure care as a focus on that and utilization, but custodial care. And the needs of someone who's 85 years old are vastly different than the services we would deliver in a physician or RN setting. And we're going to have to, in my mind, tap the wealth of our whole society in the same way that we've tapped in to meet the challenge of retirement. In other words, we certainly cannot tax ourselves to a level. There is not, as Dr. Day has clearly pointed out, there simply isn't enough taxpayers falling behind to support this. I think what we have to do is broaden our system, broaden inclusion, allow individuals to bring their personal wealth into the process, and find avenues, as we talked about before, between taking the core system and being able to expand on that to meet your needs.
Dr. Cordes, do you see any willingness out there in the terms of the public domain to actually talk about what procedures, what things the medical system is willing to handle? I know in Oregon, for example, they have a prioritized system as an example. I mean, clearly we're already not doing it. I mean, I can't go get a PET scan and put that on the system, and there's many other technologies or therapies that aren't available to me. Do you see any appetite, though, for an honest discussion about what we can cover within the medical system?
Well, unfortunately, most of what's being done now is really doing it by default through rationing care. And then, as you say, because we don't have PET scanners available, it would be interesting to see what would happen if a very entrepreneurial person built one. And I'm sure there's the demand out there for it, but they would be going way out on a limb to create, an opportunity to take advantage of a technology. But if government was to say PET scanners are the technology for this, and went out and said to the private sector, you build it, and we will provide patients under reasonable contracts, then we would have more PET scanners in this province.
It's interesting, we were talking another part about how literally doctors and nurses were rationed, that they came in 1990 in the Royal Commission and said, we got too many doctors and nurses, you want to cut costs, just don't have so many, and of course we cut back on spaces for training, and we're feeling some of the ill effect of that. I see the same thing happening now with medical technology. That it's now, yes, we do need more nurses, we've got doctors who are aging, so we've got to replace them, but I see it with technology now, the same kind of thing. You want to keep costs down, don't make it available.
I think a lot of new technologies that are available are going to be denied to Canadians over the next few years. They are being denied now, and I think that problem is going to get worse because the funding for what is already accepted and as medically, quotes, medically necessary is not there, and as new procedures, new technologies, new devices become available, they simply aren't going to be affordable to the system as we have it. I think the solution is to deal with the issue by allowing Canadians the choice to put some of their own after-tax dollars back into the healthcare system if they so wish. And right now, it's really not there.
De facto, they're going to do that anyways. They're doing it by going to the United States. They're doing it by going to India. I mean, that's what I think part of the farce is of that somebody who's been uncomfortable for 18 months in one of your realms as an orthopedic surgeon with needing hip replacement, an older person, demographic shifting, it's just saying, well, the heck of it, I'm going to the States.
There's an economic cost here, too, that's not being counted, and that is, or it's not being counted in a very good manner, and that is the deterioration and the costs of patients on wait lists and what happens to them. We saw that a lot with our program treating injured workers, that when an injured worker doesn't get treated and back to work within 6 or 7 months, the statistics are that he or she is very unlikely to get back to meaningful work. So the longer you keep someone disabled before giving them treatment, the more that's going to cost the society in the future, and no one is really counting that type of cost.
Let me just throw something out to everybody here, and that's, we're clearly feeling the strain right now. I mean, we're spending record amounts of money. Every single province is at a record amount for their budget. The feds have now just kicked in another $18 billion on top of other expenditures going back a few years. And yet we still feel the strains within the system. I don't see much sign that we've adequately prepared for that big, and I know it's almost a cliche now, that baby boom population that's going to want more hip replacements. They're going to need some aftercare. Do you see any sign of that, Rick?
I think, unfortunately, under our current circumstances, we're struggling with our present system to meet our needs. The real risk to Canadians, in my opinion, Michael, is I think we're going down a road where we talk about in this generation this great transfer of wealth, and granted I come from a biased perspective, I think a lot of Canadians are going to be hit with long-term care issues and expenditures. The system's struggling from a cure perspective. Forget about a care perspective right now. We're talking about a system that's failing just within that model. Extending that forward, I think a lot of costs are going to be borne by Canadians unless we begin the process of planning and involving private resources and innovating our system to change with that demographic and giving Canadians, quite frankly, some tax advantageous reasons to start saving for their retirement and care years and give them the opportunity to meet some of that challenge, because it will ultimately impact not just the individual passing away, but long-term care impacts 2 generations, the children of those parents. And I think it's a huge social cost, Michael.
Well, I think a good example is that what we're not doing right now, which is leaving people in the cure model, in a cure bed, at a great cost, when it should be turned over to get after another sick person to reduce the actual costs of their illness, similar to the WCB model. So we're not doing that in the public system right now. The custodial care is rationed because it's government controlled. We need incentives built in for people to take over the custodial care of their loved ones.
And I think part of the issue here, relating to what Ian just said, is that in the short term it might save money to keep those less ill patients in the hospital and deprive a sick or a patient in need of surgery access. But in the long term, it will cost money. And one of the problems with political control and governance of the system is that politicians tend to think in 4 to 5 year cycles towards the next election, and very few politicians have the vision to look at 10 and 15 years down the road.
Certainly the encouragement is to be much shorter term.
Yes.
Yeah. But we only have a couple seconds left here, but what kills me is that I don't think, David Foote wrote Boom, Bust, and Echo nearly 10 years ago. I mean, the demographic shift is something that it'd be difficult to believe that anybody in a policymaking role doesn't understand, also doesn't know the implications of that shift, and yet very little has been done. Rick, where's the inertia coming from? What's the obstacle to starting to prepare? As you said, we were earlier than Europe when it comes to the Canada Pension Plan, but we're far later when it comes to the healthcare system.
I think unfortunately, the answers are pretty simple. I think Dr. Day and all of us have touched on that. I think we have to accept that we need to open up our system. We need to utilize all the wealth in our system, both taxation and private wealth, to maximize the outcome and societal benefit. And I don't see the concern that an individual goes out and funds for long-term care, either through an insurance mechanism or a tax-favored vehicle or a combination of both.
As we do in many other aspects.
The U.S. has done it, Japan's dealt with it,
but
most other nations have.
Excuse me, we do it with retirement, though, already.
Absolutely.
I mean, we're quite prepared to do that, and I think, as you're adding, we better start doing it for our parents and do it for ourselves as we age also.
Well, unfortunately, the Liberal government, in some ways, made it more difficult to access residential care, trying to do a positive thing by bringing in this assisted living concept, which is a great concept for the boomers that are coming in and needing it, but it's doing nothing for the 80-year-olds that are plugging up our hospitals. And we've lost long-term care beds because we bureaucratized them by giving the health authorities control over all these long-term care beds. It used to be Kiwanis that ran them, or a religious society, or any of these small community groups would say, there's a need, we'll build some long-term care beds. But we don't have that now. We have a government bureaucracy that controls whether or not a long-term care bed is available.
Dr. Day, final word, and what do you see the big obstacle to starting to meet these challenges?
Well, I think the obstacle is a reluctance to look to other systems in other countries, and particularly Europe, where we know that healthcare delivery can be given at a cost equal or less than what ours is, without all of the rationing of services that defines the Canadian health system as we know it.
Well, as I say, economics is clearly going to be the driver of change here. If money was unlimited, we wouldn't be talking reform. Unfortunately, it is not, and I want to thank you for advancing this today. Rick Wilson, thank you for coming in. Thank you, Dr. Ian Cordes.
Pleasure.
And thank you, Dr. Brian Day.
Please address your comments to health_care@telus.net. Healthcare Fix is a 5-part series intended to foster debate and discussion on the state of healthcare in British Columbia.
Canadians spend more money today on healthcare than any other time in history. Yet, met with that extra expenditure seems to be a level of dissatisfaction that also has occurred at a level never seen in history. Well, joining me today to discuss how $100 billion gets spent, where does it go, is there any conflicts of interest? I've got a distinguished panel. Joining me today is Dr. Ian Cortis. Dr. Cortis is president of the medical staff for South Island Region with the Vancouver Island Health Authority, also a past president of the BCMA. Dr. Tom Perry is here also, associate professor at the University of British Columbia, but he's also a specialist at the University Hospital and Vancouver General Hospital. And also Dr. Sally Thorne is with me. She's a professor and director of the BC School of Nursing. Thank you all for being here, by the way.
Nice to be here.
Nice to be here.
Let me just start with you, Dr. Cortis, and ask, you know, you're in the hospital system. $100 billion a year is getting spent across the medical system. It seems to go up every 15 minutes. Where does it go?
Well, part of the problem is the coordination of where it's being spent. And today we're running the system in this area with 100 patients sitting in an acute care bed that they don't need at $1,000 a day, when they should be in a community bed at perhaps $300 or $400 a day. So essentially, while we're sitting here today, there's thousands of dollars being wasted because we don't have enough community care beds in this particular region.
Just as an example there.
That's just an example.
I've got
of the
many
waste.
more questions for the hospital side, but let me come to you, Dr. Perry, because I know you've done work in the pharmaceutical side, and we look at that as possibly the fastest growing area of healthcare. I was looking at numbers telling me that the drug therapies are up 15% per year. Pharmacare gets introduced, it covers 300 drugs, now it covers 3,000, and we know that next week there'll be more drugs added.
Yes, and if one were to look at the list of drugs covered, if we were starting from scratch, there is no way we would cover 3,000 drugs. Possibly 300, maybe 500, but there is still, frankly, a lot of junk there that we're using, and which has not been not met the test of cost efficiency or even safety. Sometimes we have a national regulatory agency, the Health Protection Branch, which is supposed to protect us, and yet we have only to look at the example of Vioxx, where the drug made it onto the market without proof that it was safer than other drugs. It captured a gigantic market share, and it has now been pulled as potentially more dangerous than drugs we used to use, like ibuprofen. Fortunately, in British Columbia, we were smarter than that. We did, partly through the work of our group at UBC, the Therapeutics Initiative, the government was warned that there was not real evidence these drugs were safer, and it declined to pay for them in the pharmacare program, and took a principled position that why pay for something much more expensive that hasn't been proven to be safer, save the taxpayer probably tens of millions of dollars.
That's interesting as a case study also for further. I mean, I've often wondered, you know, there'll be another new drug next weekend. Is it going to be better? Do we know it's better before we start, and how do we know that?
Usually not. It's interesting. I've been working in that field part-time for the last 7 years since I used to be a member of the legislature, and in that time there are perhaps two, certainly one drug of all the drugs we've seen that was clearly better than what we had already. And the vast majority of drugs are either Me Too drugs or are sometimes worse than what we have, and are still coming to licensing because we basically don't have a tough enough licensing system, and we don't follow up what happens when we start using these drugs.
It's interesting. There's much more to go on that, and I'll come back to that subject. Dr. Sally Thorne is also with me. Where do you see the money going, or where we could save? I mean, again, every year there's more money spent.
Well, I think one of the challenges is that we set up our current structures on the basis of assumptions of an acute care system, which means that the patient didn't really understand what was happening to them and that the physician or other healthcare professional was the expert. So we've got a whole set of gatekeeping mechanisms and controls and structures that cost a tremendous amount of money to prevent people from getting access to what they need. And I think that there are all kinds of savings that could be realized, and we learn this from consumer research. People who have a wide range of chronic conditions can point to you how many times they need to go to this one and this one and this one before they can get what they knew they needed in the first place. And I think we haven't taken a good thorough look at how we've set up systems and structures, especially in primary care, but also in the hospital sector, that have really prevented us from providing the appropriate care to patients at the time that they need it.
This may be an oversimplification, but I had a son who clearly had a broken bone, but he wasn't allowed to get an x-ray until he saw a GP, who would then direct him to the x-ray to get it back to the GP, who then went to a specialist finally. And I don't have to be an expert to know that bone is broken. Yeah. We'll start with an x-ray and I'm going to send him to a specialist after.
That's a perfect example because we've set up that system for good reasons. Back in a time where we assumed that the doctor knew best and that everybody had a family doctor and that patients really didn't have access to information. In the last 20 years, patients have tremendous amount of access to information, and they know how to use it, and they're extremely well informed. So we really have healthcare consumers being set against professionals because they understand that we're in it for our own interests sometimes.
Ironically, it's also an example of how a conflict of interest rule may work against common sense because, for example, a radiologist would not be allowed to order an x-ray because the radiologist can profit from that. An x-ray must be ordered by another physician in general, whereas in your son's case it might have been a reasonable thing to go to an x-ray clinic and have the radiologist agree with you, yes.
As I say, I'm not an expert, but when the leg's going here and then here, I said that's my first hint, it doesn't work that way.
Yes.
Yeah. Good clue. But no, it's a great point. I think conflict of interest, Dr. Cordes, is or different vested interests. Let's say, and I'll come back to Dr. Perry talking about the pharmaceutical industry, and I always hear about doctors going on these pharmaceutical trips or to learn about the latest drug, but they're learning about it in Palm Springs or Hawaii.
Well, in my area of work, we don't get the opportunity to try too many new drugs. We are primarily concerned with safety and anesthesia, so we don't see that aspect. But we do see problems with access to new therapies being denied because sometimes because of funding issues and sometimes because of turf issues. And some of these things can make things incredibly more efficient. You can get patients out of hospital quicker if you were allowed to put local anesthetic into their joint through a catheter that, however, no nurse is allowed to inject into because of issues. And so there are a lot of barriers that have to be broken down if we're going to use the system more efficiently. And we do have to get people in and out of the hospital as quickly as possible. They're expensive beds, but at the same time we got to make sure they're going out safely because we have a lot of people going out the front door and then back in through emergency because there's so much pressure on the remaining acute care beds that aren't occupied by all these elderly people waiting for placement in the community. And so the system right now is highly inefficient because the right things aren't being done at the right time in the right place.
I agree. Some of those are structural barriers. We probably do have enough nurses and doctors if we were using them appropriately.
Are you saying that nurses should perform other duties, and is that when you say using them efficiently, or is it a case of restrictions in the work contract that prevent them?
Both, but there have been a lot of restrictions with regard to scope of practice across the full range of healthcare professions, and I think many of those are starting to be worked out now. We're just on the brink of having nurse practitioners in the province, and I think from a primary care point of view, although they'll work in many sectors, from a primary care point of view, they make tremendous sense and work collaboratively with family physicians and others to really provide a level of service that is much more appropriate as well as being cost efficient in reaching British Columbians.
Mike, to come back briefly to the issue of conflict, I think it touches on a more fundamental general point. It's fashionable nowadays, particularly in North America after the U.S. presidential elections, to downplay the role of government in protecting people. But ultimately, if you think things through rationally, in a world where there are many commercial interests that may impact upon health expenditures and on what people are encouraged to do, One of the few agencies that can protect the public is a democratically elected government with high-quality, competent people in its regulatory branches. We have tended to erode that severely in North America, including in Canada. I'm very concerned that compared with 25 years ago when I was a medical student, the regulatory environment is actually no longer anywhere near strict enough in Canada to protect the public. And as you know, one could give many examples, but here's one that would affect many older viewers. In the area of osteoporosis, we now have private clinics encouraging people to come for bone densitometry scans. Sometimes I've seen mobile vans at shopping centers recruiting people. There are doctors' names attached to that, and those doctors must be in conflict of interest because they are effectively soliciting patients. I'm not suggesting they're not well-meaning, I'm sure they are, but they are conflicted because they earn their living through something which has impacts upon patients' expenditures, public expenditures, and no one other than a competent government with the support of independent academics in universities is in a position to tell the public, this actually benefits you, this is neutral, or this may lead to harm. Such issues arise in prostate screening, for example, where it seems a good idea to get your prostate PSA measured, but it's very questionable whether that leads to more benefit than harm. It may have a net harmful effect on people, and yet there's lots of money to be made in that field.
We've just balanced that, though, with part of the problem they aren't regulating well is they're spending too much time trying to deliver care. And that there is only so many public dollars. We're only willing to tax to a certain level, and I think we do have to decide what the priorities are for government. And I totally agree with Tom that regulation is something government should be in. Delivering care is not something that should be totally government controlled. There is no reason that private or corporations can deliver care. They have to be held responsible to certain levels of quality of care, but there's no reason that you can remove it from the complete public control that it's under right now.
It's interesting just hearing the conversation that governments obviously have some limit to resources. It would be naive to suggest that's not the case. And yet, it seems that at least publicly, we get told all things all the time, any place, any drug, any therapy. You know what I mean? We get told that. That's the talk. Now, behind closed doors, they're rationing. You know, they are
totally
making this priority, and as you say, into acute care, they haven't taken care of chronic care beds, so they come in, and certain tests are not funded at this point.
Yes,
so
and another important and complex issue is that not all waiting lists are bad. A waiting list for someone who suffers intensely, such as Dr. Baker has referred to on this series, with a bad hip or knee, where a surgical operation can greatly improve the quality of life, there's no excuse for an unreasonable wait there. Waiting for heart surgery in some cases has undoubtedly saved people's lives, as well as cost them.
Yes, yeah.
But probably saved more lives because some problems resolve and some people have avoided dangerous surgery where there's a much higher chance of dying or having a major complication. So the trick with waiting lists is to attempt in a rational health environment to make sure there is no long wait for definitely beneficial procedures, and to avoid those procedures which are not beneficial, and there will in between be some point which is tolerable to people. But we should not necessarily be aiming for the American standard of bang, angioplasty, bypass operation, get your hip fixed at the same time, which is highly entrepreneurial and is driven by the financial interests of hospitals, doctors, and anyone else who can make money off of it. We left that behind in North America with snake oil salesmen in the 19th century, and we do not want to go back to that environment.
Let me just ask you very quickly here. Sorry, there's just, we only have about a minute or two left, so it's got to be the Barbara Walters quick answer here. But you know, where can we save money in this system? Just bottom line, if you could wave your magic wand and we could we hear the word efficiency, but that's all we ever hear. We don't hear really practical applications. I haven't seen any reforms or innovations that have dealt with that directly. I'm sure there are a few, but it's not been the overwhelming sentiment. So, Dr. Thorne, I mean, if you could, one area that you see, hey, why don't we save a couple $100 million?
Well, I think we could save a lot by really taking a very hard look at who is out there and what their most effective scope of practice, what is the thing that they are best at doing, and how can they be put in a position where they can do that well.
So in other words, the extreme of that would be, we don't have our doctors walking around changing bedpans, because that's not the best use of their expertise.
We have our nurses in situations where they're not able to get close to patients, they're not able to do the observation they're supposed to be seeing, they're not able to connect to order order to predict, and it's really a problem.
Dr. Cordes?
Well, I think there's two aspects. I guess if I only get to wave the wand once, I'll deal with.
We only got about 30 seconds, so.
We'll do the acute care system, and that would be to create more coordination between community care and acute care. I think the current model is not working. Interestingly, now we have the health authority controlling both, but they're not coordinating both, and there's silos within the big silo that need to be dealt with.
Dr. Perry?
I think we need to start by teaching our own professionals, including my own profession, to understand more of the costs of what we do, make us accountable for that, and pay us better for good quality.
Great stuff. Dr. Ian Cordes, Dr. Tom Perry, Dr. Sally Thorne, thank you all for being with us today.
Thank you.
Thank you.
Please address your comments to health_care@telus.net. Healthcare Fix is a 5-part series intended to foster debate and discussion on the state of healthcare in British Columbia.
Concerns about waiting times for surgical procedures seem to top Canadians' list of what their dissatisfaction and what their worries are concerning the medical system. To discuss this very important topic, I'm joined by Dr. Milton Baker. Dr. Baker is president of the Medical Society in Victoria, also president of the BC Rheumatology Society. Also joining me is Dr. Sally Thorne. Dr. Thorne is professor and director of the UBC School of Nursing, and Mr. Rick Wilson. Rick is regional director for the Group and Living Benefits Division for RBC Life Insurance in BC. Let me start with you, Dr. Baker. Give us an idea of some of these waiting times. They seem just to be getting longer and longer in the country.
I think we have to define exactly what we're talking about here. For instance, in BC right now, the average waiting time for a total knee is 18 months, for a total hip is 11 months, and these are increasing at the rate of 10% every 6 months. On a national basis, the waiting time for referral from a GP to a specialist is now 9 weeks. The average time from a GP referral to a treatment is now 17.9 weeks. And this has gone up every year since they've been recording this. So we have a very big problem here.
Well, what we tend to do, Dr. Thorne, is think that it's only a problem about money, and yet we know that Canadians spend more money on health care per capita, age-adjusted basis, than any other country in the Western world. I was looking at an OECD study that was kind of frightening that said for every $100 that we added to the medical system per capita, every other OECD country reduced the waiting list. We actually extended ours by a week. What's behind that? Do we have any idea why that keeps growing in spite of the amount of money being thrown at the system?
Well, I think we do, and I think the Canadian consumers are getting pretty sophisticated about understanding that none of these are simple problems. A few years ago, or recently, we had problems with emergency room overfilling, and Canadians became aware that the answer wasn't just to increase the number of emergency rooms, but to recognize why they were full. And that had to do with not enough home care, not enough extended care and long-term care, not insufficient primary care. People didn't have family doctors, and so they were finding their way into an emergency room. And I think with all waiting lists, there's a similar level of analysis that Canadians need to get into to really recognize that there aren't simple solutions.
Yeah, Dr. Baker, you were mentioning about 11 months for a hip replacement. That means I sort of go see my doctor, I'm limping, and they come and
People
say,
are
you
suffering.
need something. Yeah.
People are definitely suffering, and it's costing more. They've already done cost analyses that the amount of money spent in a person waiting for a year for a total hip exceeds the cost of what the total hip actually costs.
Well, we just had our political leaders, all the provincial governments, the federal government, all get together and pronounce that they're going to spend another $18 billion, and we're going to reduce waiting lists. And it brought me back to Saskatchewan in 1999 that had a goal of reducing waiting lists by 30%. 5 years later, they're up 61% longer. What are they missing? I mean, what are the ingredients, the building blocks to attack this problem?
we don't have a market responsive system. We have a top-down monolithic system that excludes alternative methods of funding. And this is the difference with Europe. I mean, all these countries you mentioned, none of them have the kind of rigidity that we have in the Canada Health Act that makes it so difficult for any private money to come into the system. It's inflexible and it doesn't respond to the market needs.
But you were mentioning, I mean, it is important, I think, for Canadians to understand that, yes, other countries have waiting lists, but many countries don't. I'm thinking of France, Switzerland, Germany, Austria. The list is quite a long one. Greece comes to mind. That these are countries with public pay health service, universal health care, and yet they manage to have no waiting lists.
But they also have ability to pay privately in those companies. None of those countries have outlawed private health care or made it difficult to supply private health care.
Let me go to Rick Wilson here. Rick, you know, doing insurance for healthcare, is this where that's leading? What role can that kind of approach?
I think, to take off Dr. Baker's and Dr. Thorne's comments, I think what we see is we see the public's response to these issues. So if I look at the development of certain products in the last few years and the popularity of things like critical illness insurance, a growing awareness of long-term care insurance, I think really what we're dealing with is there's a recognition that the core system is failing and that those margin in services aren't being met. And I think a certain degree of the population we've seen are reaching out and saying, I'm going to reach into my own pocket to close that gap between what I know is there and what I really want and need from healthcare. So I think our role is just to be responsive to those things and try to innovate wherever we can in terms of meeting need out there for the patient or the consumer.
Well, one of the stories that we're getting echoed, and maybe a little bit piggybacked on that, are you know, stories of literally hip replacement plane rides to India. You know, that we know, medical tourism, exactly.
Absolutely.
And we certainly know that's been, I mean, provincial governments have contracted out with American facilities. I know in cancer patients in, I believe that was in Ontario, heart patients I know in BC in the past, but, you know, we're seeing this kind of thing. Is that the kind of, will I be able to purchase insurance in that way and then not use it in Canada?
Well, I think first off, I mean, I'll express a personal opinion around the issue. We have a two-tier health system. It's called the United States. There's nothing that we can do to change that. I think we have to speak in a very open and common sense manner about that. And that's certainly something I've expressed. But I think more importantly, the industry is responding with certain products. There's been a product developed in Canada that effectively gives a Canadian access to the U.S. healthcare system. We look at the popularity of such programs as Best Doctors, which really is a component we're starting to see in critical illness programs. We're starting to see it in group benefit programs, and we're starting to see it as a standalone offering. And really that offering is an offering that really gives a suite of 3 services to people, InterConsult, Find Best Doctor, and Find Best Care. But I look at that as an expression of the frustration that we're seeing out there by the public around some of the failures around the system. And people are reaching out, and now they're starting to reach into their own pocket and saying, I'm concerned about these issues. And I do have the finances, and I do have the concern about this issue that I'm willing to pay for this.
Another element of that is that we're very comfortable with the idea of a publicly funded system, but in Canada we haven't figured out how to have conversations about public accountability for what it is that gets you on a waiting list in the first place. And I think that many of the waiting lists, there's no question that there are suffering people on them, but certain waiting lists inflate or deflate for reasons other than the numbers of patients and the numbers of operating rooms. And I think that where clinicians and clinician groups could get together and really create auditable set of standards as to what constitutes an appropriate case on a waiting list and what the nature of that waiting list entails, then we'll be able to know whether a reduction or an increase actually is making a difference in the health of British Columbians.
Well, what worries me is, again, we know that phenomenal amounts of money have been added to the healthcare system. You know, I mean, the numbers come, we keep on growing, and yet this is a problem that is top of the list, I think, in Canadians' mind. I mean, I want to be able to get some surgery if I need it, and it doesn't have to be life-threatening, but it can certainly be lifestyle-threatening. I mean, you can have, as you were mentioning, Dr. Baker, if I need a hip replacement, that means I'm not walking, I'm not playing golf, I'm not doing these kind of things.
These are real people with severe problems. Some of these people are living in chronic pain. They're having to take pain medications which make them sick. Some of them are going to get other diseases in the meantime because of this, and that's not going to show up in your balance sheet. It's going to show up coming out of other, the welfare rolls, the other social services. You won't see that cost. basically it's unethical for a system to not provide the service in a timely manner and also not allow you the ability to pay for the service in some other way. I mean, this is a basic, it's something wrong with the system. And until it recognizes that and allows more flexibility, you mentioned contracting out. I think the future should be contracting out inside Canada. Why should you have to go outside the country and see a Canadian doctor and a Canadian nurse who's fled to the US so they can get paid appropriately when they could do it here and have the facilities here and everyone benefits?
What would you do if you could have, and time is always short and these are broad discussions, and I appreciate that, but to get us started, again, we had every political party, various stripes, premiers from various political parties. We had the federal government and the health minister federally all get together and say, okay, here's $18 billion, and we're going to really go after that health care waiting list problem. What would you suggest to them? Where would you start in order to make a fundamental difference in this? Because clearly it hasn't worked to date.
It's not just a money problem, it's a system problem. That's why just putting money in and playing games with figures and talking about try to control the promises to spend it in a certain way, that'll never work. You have to have a market. It's basic economics. You've got to have it market driven. This top-down dictating, there's not enough flexibility, it's inefficient. There's all kinds of inefficiencies to the system that are made up by the system. I think that kind of thing is doomed. I mean, it will never do what we're expecting it to do.
Well, I think there's some advantages to top-down policy discussions, and I think that's been a useful thing in Canada to try and wrestle with which are the values that Canadians really do hold to and want sustained in their healthcare system. But we haven't yet found the appropriate economic levers to ensure that those values are enacted in the way we do business in healthcare and the way we deliver our services. We don't know, for example, how to reconcile individual clinician autonomy with a publicly funded system, which has very scarce resources, and we're going to have those conversations as a society over the next little while. There is a limited set of resources, and we do have enough to deliver proper health care.
I think some of the commentary here, Dr. Baker, you talked about rigidity. What I find amazing, and I look at it from a historical perspective in our healthcare system, are we dealing with, and some of the conditions you're talking about, knee replacement, hip replacement, I don't know that our model fits our current demographics. If I look at some of the utilization numbers I'm working with, we're dealing with a population right now of over age 65 that's utilizing almost 50% of the hospital expenses according to the CIHI. And again, we're in that challenge of let's continue to throw resources, but we're not solving the problem here of quality of life for people. And I think it's beholden on us as Canadians, I'm speaking as a layperson, that we challenge ourselves to reinvigorate our system and have that model match where we want to go as a society. When universal health care was first brought in, the demographics of the Canadian population were rapidly different. And I don't need to educate any of the medical people here on the impact of that. But I think change is needed.
And the technology has improved. So we don't realize that our expectations are higher, the ability to help people is higher, but that costs money. People want top quality care. You can't provide that with $1970.
One of the good news stories, though, is that we're starting to pay attention to chronic illness and chronic disease self-care management. And until recently, that's been a subtext. It's not been the important story. It's been critical care and acute care. And who is it that's in the acute care system? Over half is people with chronic illness, and a great deal of chronic disease self-care management can reduce those hospitalizations and those acute episodes, improve wellness over time. And I think we have to invest a tremendous amount of money in the chronic illness system, in primary care, and in helping people live better with the diseases that they have.
Let me just ask you, and we don't have much time left here, but I'm always amazed at the lack of change within the system, the lack of innovation within the system. Just your own point of view, what's the number one obstacle? Because I talk to professionals who are in the system like all of you are, who are participants, see it front line, and they have many, many good ideas, and yet nothing seems to change on a broad base. And I'm just wondering, just from your observation, what's the biggest obstacle to moving forward in these issues?
Because this is run top down. Government to the hospital administrators, they have very little flexibility in what they can do with their money. They're so bare to the bones now. That works all the way down the system. Some of them have good ideas, but they don't have the extra capacity or the extra money to be able to do anything innovative. And I would really guard against too much rigidity. she mentioned that somehow maybe some people or shouldn't be on the waiting list because they don't need to be. I think it's very important to keep that doctor-patient relationship. We have people are not all the same. Some people have different reasons for needing these things done, and I could just foresee a system where there's a computer printout, and if you don't have this kind of criteria, then you'll be rejected, and that's making, like big government, making more rigidity, actually. We can sometimes phone up people and get things done a little quicker by using the personal touch, and by taking that out, you're going to make it a totally robotic system, and I think that's the problem, is that robotics don't work.
Well, I don't have quite as cynical a view. I do think that good public decisions can be made without going quite to that extreme.
Standards,
but I think
yeah.
that the biggest limiting factor is 4-year election cycles, and I think we have a shortage of political leaders and public leaders who are able to take a really strong stand regardless of re-election.
Mm-hmm. But I think Dr. Thorne's on some of the issue. I think if you talk to most politicians, they know the type of data that we're talking about. I think some of it's self-preservation. You're looking to keep your job and be re-elected. Canada is going to go through this change. That's my opinion, Michael. Whether we're sticking our finger in the dike. I think the issue is how we're going to make those choices as a society. I think some of the obstacles are partly information and how it flows. I look at it from my perspective. I have a vested interest in this topic, obviously, but I look at the steps I've taken to educate myself around the subject, and I think once you get back and you start looking at some of the facts, and you start moving off looking at the American system as the only thing that we can compare ourselves to, and we begin to broaden our perspective, and I look at some of the work of Dr. Gratzner and Code Blue, you begin to start looking and begin to realize that there are many ways that we can organize our healthcare delivery system for the benefit of everyone involved without throwing out, I think as Dr. Thorne said, some of the core values. I don't think this is a challenge to universality. I think the issue is innovation at the delivery, and really that at the end of the day, in my mind, innovation for me as a voter in terms of how I want to allocate resources to healthcare or how I define that quality piece. Some people will have a different response to that, but I want the freedom to be able to do that and make that choice. I'm asking for a democratic right here. That's the obstacle.
Well, now you've opened up a can of worms. Unfortunately, we don't have much more time to deal with that. I want to thank our panelists today, Dr. Milton Baker, Dr. Sally Thorne, and Mr. Rick Baker for coming in. Rick Wilson for coming in and sharing their views on this today. I think it's a great topic and one that I hope we just spur debate here. We're not solving it in 15, 20 minutes, but I hope we have done exactly, and I've appreciated your views on the subject. Thanks for coming in.
Please address your comments to health_care@telus.net. Healthcare Fix is a 5-part series intended to foster debate and discussion on the state of healthcare in British Columbia.
Perhaps the most contentious issue in healthcare today is the role of the private sector in delivering our health services. Joining me to discuss this controversial topic, Dr. Milton Baker is with me today. He's the president of the Victoria Medical Society, also president of the BC Rheumatology Society. Also joining us is Dr. Tom Perry, associate professor at the Faculty of Medicine at UBC, practices at the UBC Hospital, Vancouver General Hospital as a specialist, and Dr. Brian Day is with me also. He is the medical director of the Cambie Street Surgery Centre, also again teaches on the Faculty of Medicine at the University of British Columbia. Gentlemen, welcome.
Nice
Let me just start with, isn't this whole debate about private care and public care a bit farcical, given that there are private doctors' offices right now, chiropractic offices are private? I mean, there's a huge component of private care already in existence, Dr. Baker.
This is not a black and white issue. I mean, we can talk about publicly funded, privately delivered care, privately funded, privately delivered care, components of that, partially funded, certain diseases funded, so it's a very complex issue. But I think what we're discussing is the capacity to increase the private component in healthcare to relieve the shortages and also provide the system with some accountability.
Dr. Perry, you're a long-standing proponent of public care. Again, I come back, haven't we just, as Dr. Baker's alluding to, haven't we just oversimplified this to a ridiculous extent? I mean, I remember in the 2000 federal election when Jean Chrétien didn't want to admit there was any private care until he was corrected by then Health Minister, I think Alan Rock at the time. 30% of the expenditures are already private.
Yes, and where I would probably agree with my colleagues, I think we often delude ourselves with rather specious arguments. I work essentially as a private sector provider of health care paid for by the government. To me, the important thing is always to go back to the basic principles, why we developed a publicly funded health care system in Canada in contrast to the Americans. My late father was an American who tried and hoped very strongly that the Americans would achieve that. Their system, I think, in many respects has failed by global standards. It serves some people very well and other people exceedingly poorly. And we're much more in keeping with most developed countries. But the key issue is to think, why are we doing things, and how can we best serve all of the public regardless of their socioeconomic status, their level of education, their wealth, and ensure the democratic values that most of us do agree on.
Have we, Dr. Day, become a little confused, though, about the difference, as Dr. Baker was alluding to? There could be private pay for private care, and for example, if I go to a chiropractor, I may engage in that. They're a private office, and I pay them privately. But there's another side, which is private, it's a public system, but a private facilitator handles it.
Yes, and I think to pick up on what Dr. Perry was saying, this tendency to look upon the Americans as the alternative, I think, is where we fall into a trap. There are systems in Europe, in France, in Germany, in Holland, in Belgium, Austria, Greece, where there is a mix of both private and public funding and delivery. And these are countries, unlike the United States, that have universal health care. And I think that, that poor people in those countries do not wait for health care. If you're poor, you get an MRI when it's needed, you get a hip replacement when it's needed, you do not hobble around as you do in our system for sometimes up to 2 or 3 years waiting for health care. So I think that what we started out with probably now 40 years ago in concept anyway has now evolved to a situation that we're seeing extreme rationing of the delivery of health services, and I think what's needed is a change in the system.
Dr. Perry, does it worry you, the company we keep, when we are the only system that ostensibly says no private care, us in North Korea? I mean, that's it. I mean, when European, see, I worry that it's become this sort of left-right issue when clearly social democratic countries in Europe have got a parallel private system that the public system also takes advantage of.
Well, I would go back to basics. I lived briefly in Sweden, which is a social democratically influenced country in which, for example, there were very small user fees. I've personally varied in my opinion of user fees over the years, and on balance, I think they're an inconvenience that probably costs more to collect and administer than they're worth, and I don't think they will deter most frivolous visits. I'm not sure whether the Swedish system is a wise one or a bad one. It's almost irrelevant, and it adds another layer of bureaucracy to collect those fees. But
what's interesting is the Swedish system, the biggest owner of private medical systems around Stockholm are the nurses union. Second only to the doctors union, and the numbers that I'm seeing coming out of Sweden have been very, very positive, whether it's for the employees, whether it's for productivity, and clearly more access for patients.
I'm sure they are. I would go back in Canada to look at some very simple questions and much harder answers. Our system has worked remarkably well by world standards until recently. Probably in the last 10 years it has begun to fall into serious problems, and there are many factors: changing in population growth, shortage of medical and nursing and other professionals that complicate this. But what we really want is we want to solve our problems as efficiently as possible with the lowest total health care cost to society. As Dr. Day said, the American model is one of the worst in the world is certainly not the model to follow. Some European models are as good as, possibly better than ours. Japan has good models. And we should really be asking ourselves, how can we ensure that our citizens are well served on a democratic basis in a way that protects everyone, so that all people, regardless of their status in society, have equal access to important and valuable health services, and that they don't get too much junk thrown in there with it.
But haven't we seen that successfully, Dr. Baker, when we look across the sea to France, to Germany?
Well,
no
even
waiting
Britain.
list, doesn't matter rich or poor, access is there.
Even Britain, which started the socialist system post-war, is now majority private. But even in Britain, they never did away with the private healthcare system. We are actually engaged in a huge social experiment. This has never been done before, what they're trying to do here. And the healthcare economists who are making these decisions, what bothers me is there's no accountability. They can make these decisions, bad things happen, and it never comes back to haunt the healthcare economists. And did Canadians really agree to this huge experiment in this system? I don't recall anyone voting for this monolithic system.
We have an example of a European-style health system right here in British Columbia, and that is with the Workers' Compensation Board. This is a mixed public-private funder of the service. There is mixed public-private delivery of the services to patients, and since 1999, when they started contracting out to the private facilities, and not only have the wait lists dropped to the level that now all injured workers receive if they need surgery, they get that in under 20 days. They get an MRI if it's needed, for example, within 2 days, and at the same time, not only have they saved hundreds of millions of dollars in wage loss benefits, but it's the only jurisdiction in the country in which the costs of healthcare delivery are falling, and they've dropped over that period of time from $212 million a year to $189 million a year. So this is not some experiment we have to theorize may or may not work. We've seen it work in British Columbia.
I just want to be clear what you're talking about is the Workers' Compensation Board has injured workers, obviously, and then they contract with a private facility to have it done. I just wanted to be clear that people are with us on that.
Mike, one of the difficulties of comparing with other countries is each medical culture and most of the societies are very different. Comparing France, Sweden, Germany, even Britain, they're very different countries from Canada. But one of my concerns is that our hospital sector actually has underutilized capital now. For example, we have so-called reduced activity or RAD days that typically catch unprepared doctors like me by surprise on a Friday, when routine tests cannot be performed. Patient is delayed in hospital for, in that case, 3 days until the next Monday. Before we go chasing off further into the private sector, now that we have a surplus in this province, we ought to be reopening our hospitals back to I suspect Dr. Day and Baker would agree with me, we ought to reopen back to the levels of service we enjoyed prior to, say, 1992.
But isn't that, I mean, there's a number of reasons always, we don't oversimplify, but to give an example, the inflexibility of some of the contracts we have with our nurse professionals, for example, would raise bloody blue murder if you try and go in. I mean, it's easy, I would agree with you, let's go in and maximize the facility, but it isn't going to happen.
Well, the government has proven that it can change an inflexible contract by simply making it null and void. And when it does so in the public interest, there are a lot of voices raised, and sometimes people will support the government. It does have, as a famous politician once said, virtually unlimited power to do what it wants in a parliamentary system. So we can change contracts. What has really limited us there were two factors in British Columbia. One was money, and the other was the supply of skilled and trained nurses and their willingness to work.
Which we should add, though, was a purposeful program coming out of 1990's Royal Commission into Healthcare, when they said one of the ways to cut healthcare costs is to lower the number of doctors and lower the number of nurses.
Yes, and there was the challenging issue that nurses had been, still are predominantly female. We're beginning in the early 1990s, late 80s, saying, look, we're not going to work for wages which are grossly undervalued compared to male professions, and that the resulting rise in the cost was enormous for society. We were riding along not paying for what we were getting for not only decades, but at least 100 years in Canada.
But the Barrow-Stoddard report in 1990 that came forward, this is the basis in which medical school enrollment was cut back, specialist production was cut back. This was the healthcare economist who said somehow there were too many doctors. If you cut down the number of doctors, there'll be less costs. And the government bought this. And this is a huge disaster for our healthcare system right now, because you have a few people at the top who make these decisions that then impact the whole society, the whole healthcare system for 20 years. We're looking at a huge deficit in physicians, and it's going to get worse before it gets better. We've got the baby boomers coming along, and we've got doctors retiring.
And we have an aging population of doctors and nurses.
Even so, Micah, Brian will correct me if I'm wrong, but I think if you spoke to almost any surgeon in British Columbia now, they would tell you, given more operating room hours, they would operate on more patients. Certainly all of the surgeons I know would answer affirmatively. Now, why is it that no government of any political stripe, whether it were Liberal, NDP, or Social Credit, has been able to reopen hospital operating rooms to accommodate those surgical needs? That's crazy.
Well, I can answer that, and it's the fact that the monopoly provider of a service is never good for the consumer, and that's basically what we've had in Canada now. And you have to, I think it's a mistake not to look at countries where they have universal health care and it works. I mean, Canada's health system on an age-corrected basis is the most expensive of all countries that have universal health care. So if you go to France, they have a considerably cheaper system of delivering health care, and patients don't wait. I mean, the patients in British Columbia now are even waiting for cancer treatment. They're waiting up to 6 to 8 weeks in Vancouver for a biopsy once the family doctor says there's a suspicious tumor. Well, this is clearly unacceptable, and we're now ranked 30th in the world by the World Health Organization. When we have those kind of statistics coming out of the OECD and the World Health Organization, and we are costing more than any of these other countries, we have to start asking real questions and demanding answers from government. And my proposition is that the reason why our government is not delivering healthcare in an economically reasonable at an economically reasonable cost in an expeditious time is that this is a monopoly at work, and monopolies, it's axiomatic in my opinion that monopolies are never good for consumers.
We've only got about a minute left, Dr. Perry.
I think it's a little more complicated than that. I think Dr. Day's private clinic would not be so successful if it weren't providing a useful service at a very high quality. But we have similar examples in our hospital system. Hospitals have competed with each other in the past. For example, St. Paul's Hospital in Vancouver became a center of excellence for HIV and AIDS by seizing the ball. The Catholic sponsorship of the hospital said, we want to treat people who are otherwise looked down on by society. Not all hospitals did. That was an example of competition. Right now, we do not foster competition even between health regions. For example, to make Fraser Valley or Victoria a center for excellence in hip replacement, allow them to compete with other parts of British Columbia and export people, if we had to, from Vancouver to Victoria to fix the hip waiting list. That's discouraged because, as Milt said, there's no accountability. No hospital administrator ever loses their job for not doing a good job.
I'll give the last word to Dr. Baker here in a second, but first I'll add, I never see the word excellence repeated. We have clearly not had excellence. You have, Dr. Perry. You have,
we have a lot of excellence in British Columbia. Let's not underrate ourselves too highly. We have wonderful doctors and nurses.
But it hasn't been an aspired goal in Canada, in the Canadian healthcare system, where you wouldn't slip to 30th, you wouldn't slip to 16th in access to new technology. You wouldn't slip. There's a lot of measurements.
I agree with you entirely on that. Our outcomes in many respects are far better than the Americans, although we spend much less money than they do, because we have such excellence in our public system. It's not perfect.
We want incentive.
Baker, very quickly.
We want incentive in the system and accountability, and it seems to me totally illogical in a free country that a patient has no alternative to their health care. If the government cannot provide it in a timely manner, why do they not have the right, a person have the right to get it somewhere else inside this country without having to take their money to the U.S. and pay the U.S. system?
And we can all agree on that. It is a governmental responsibility to provide it one way or another.
Well, my dog gets treatment very quickly. Dr. Milton Baker, thank you for taking the time. Dr. Tom Perry and Dr. Brian Day.
Thanks, Michael.
Please address your comments to health_care@telus.net. Healthcare Fix is a 5-part series intended to foster debate and discussion on the state of healthcare in British Columbia.
Often in the debate surrounding healthcare and healthcare reform is lost the individual. Where's the individual in all this? We know what government should do, or nurses should do, doctors should do. What about you and me? Well, joining me now to discuss this topic is Dr. Tom Perry. Tom teaches at the University of British Columbia as a specialist both at the University Hospital and Vancouver General Hospital. I've also got Dr. Sally Thorne with me. Dr. Thorne is the head of professor and director of the UBC School of Nursing, and Dr. Brian Day is here, also medical director of the Cambie Surgery Centre. Again, associate professor teaching at the University of British Columbia's medical faculty. Let me start with you, Dr. Perry. And what about the role of the individual? I mean, has it changed? Should it have changed over the last 20 years?
It's a very important issue to discuss because in healthcare, one of the dominant issues facing us in the future, if we think we have problems now, is the wave, for example, of obesity and diabetes coming upon us. And this represents the crucial mixture of social forces pushing junk food and consumption of junk food, and the individual's responsibility to look after themselves and resist those forces. Mm-hmm. I see it as a problem that requires a combined solution. I'm very pleased that your brother, actually, the Premier, announced that he's going to remove junk food from British Columbia schools over the next 4 years. I wish he would do it today. But I commend him on the leadership of starting to move in that direction. At the same time, you cannot absolve a young person or an adult from some responsibility for their own health, and we have tended to do that. We've excused virtually everything, whether it was drug abuse, alcohol abuse, tobacco abuse, gross abuse of food and calories, or sedentarism. We will pay for that in due course, and we're already paying for it now.
It's interesting, you see, as you say, our lifestyle change is now resulting in huge costs to the healthcare system. We're familiar with smoking starting in the 50s and 60s. I'm not so sure there's an excuse to do that, unawares of the impact on your health today. Dr. Thorne, what about yourself? What do you see as different that way, and the role that the individual can play to help solve some of these healthcare challenges?
Well, I think there's a huge role for the individual, and I think we who are in the health professions really have to take some responsibility for having systematically convinced a population over a very long period of time that they didn't have the expertise that it took to make a difference. Mm-hmm. And for example, there's a 1935 ad by the Canadian Medical Association which has a young woman at a graveside saying, "Mrs. So-and-so thought Johnny only had a cold. If only she'd taken Johnny to the family physician." And I think that we have really had a culture in which we've convinced people that they need to get professional advice for all aspects of health care. And I think that's an important part of rebuilding individual responsibility.
Yeah, I think you go to any clinic, or something, or emergency ward, and I've talked to emergency doctors, and they'll tell me anecdotally, it says, yeah, we got a lot of colds.
And the reason that's important, I work a lot with people with chronic illness, and they are extremely aware of how many barriers we've set up in the way we orchestrate mm-hmm. healthcare for their being able to actually enact what they know they need to manage their chronic condition. So I think that it's extremely important to kind of uncover the ways in which we've set up rules and regulations and access to systems, because we've actually, I think, made it very, very difficult for people to take full responsibility for maintaining their health, for managing their chronic conditions, and for living as well as they can. And that's an important thing that we need to pay attention to in healthcare.
Dr. Day?
Well, I mean, I think there are examples, and perhaps obesity and diabetes and the relation is one, where an individual or the parents of an individual have to take responsibility. But I think that also we have to accept that in a free and democratic society, we do make societal decisions, and for example, some people choose to smoke or drink. We choose as a society to drive our vehicles at 70 kilometers an hour. If we as a society cut the speed limit down to 5 kilometers an hour, we'd save a lot of deaths on the road. But that's not a realistic choice. I think that there are many instances where preventative medicine has not been shown to be certainly a cost saver for the system, and that's really the big issue facing the healthcare crisis in Canada now is the economic issue. As Red Fox said, one day health nuts are going to find themselves lying in bed, dying of nothing. And I think that there is, I think where individual responsibility should be allowed and is denied in the Canadian health system, for example, is in being able to look after yourself if the government chooses not to. And essentially that's what we have with our Canadian delivery system of healthcare, a system in which the government has promised to deliver timely, accessible healthcare in a comprehensive manner, is failing to do that, and at the same time denies Canadians access to the means to look after themselves, and actually denies them that access, legally denies them. It's actually against the law to go out and look after your own health needs by buying appropriate insurance for something the government is not delivering. Fine, if the government can deliver it, I would agree with that, but no government in my opinion, can deliver everything the consumer wants or needs in a realistic world.
Let me just talk, I mean, it's an interesting point about our governments have purported to do so much for us in the healthcare front. I mean, the reality and the promises may not exactly match, but they've made a lot of promises. Dr. Perry, do you think that that's actually not empowered individuals? It's sort of taken them off the hook. You were mentioning obesity would be a great example. I think we all understand that exercise might be a positive thing for most of us, and yet we don't practice it. But is it just let us off the hook that way?
Well, I think we're getting to the point where we're getting stuck by the collision of different forces. For example, we know that exercise will not prevent Alzheimer's disease. It will not prevent people from requiring hip replacements. It may, in fact, increase the need for hip replacements. But we know that in general it is good for people for a healthy lifestyle. We know that that ought to be taught and reinforced in our schools. In fact, we are doing less in our schools, in part because we are sucking money out of the school system into the health and sickness care system inexorably, pulling out of every field. We're pulling money out of the pockets of poor people. I've had patients literally where I would have preferred to give them cash rather than drugs if I were allowed to. The cash would have been far more useful than even the hospital treatment in some circumstances. We know that housing is important for mentally ill, and yet we have lacked the funds to do that for years. We at some point have to, despite the importance of sickness care for people, and despite the crucial importance of looking after people with serious life-threatening and painful conditions, we have to ensure that we put money into those social determinants of health. Now, the other prescription I would give, since this has been a discussion about a lot of problems but not too many solutions, for the average citizen watching this program is insist for once that the schools teach health literacy to people. I think the single most disappointing aspect of my life as someone in my mid-50s is that the level of knowledge about health is, as Dr. Thorne pointed out, probably declining, not increasing over time. We live in a highly advanced scientific culture, and yet our average high school graduate knows virtually nothing about their body, not even how to take their temperature, and sometimes not even how to weigh themselves reliably. That is shocking, and it needs to be fixed fast.
Yeah. Another part of this challenge is that we're living in a world where politically and in the context of decision making, we base a lot on evidence, and we don't really understand what kind of things we are likely to have evidence for and what we're not going to have evidence for.
Can you just elaborate that for us?
Well, we don't have, it's very easy to say we don't have any evidence for preventative medicine, for example, but most healthcare consumers know that eating well and living well and maintaining their health and attending to the episodic illnesses that happen over the course of a lifetime makes a big difference. It takes a lifetime in order to evaluate that, and lives are so complex that you can't distill one factor and say, did I or did I not eat a lot of Big Macs early in my life, and what kinds of illnesses did it cause? So I think we have to take a leap of faith and recognize that science won't be necessarily what's telling us explicitly about the relationship between certain health behaviors at different points in our lives and certain other kinds of outcomes later on. But it makes tremendous common sense to put reinforcements in society for people to be able to live as well as they can, as healthily as they can, and to solve their health problems as efficiently and effectively as they can, so that we can prevent them from having to be in the hospital care system, for example.
I think I'd echo what Dr. Perry was saying in terms of what we're seeing now is because of the pressures of healthcare economics, that we are depriving other important duties that governments have of the resources needed. For example, the recent announcements about earthquake resistance in schools, elementary schools in this province are in dire need of upgrading to make them earthquake resistant, and yet that budget for healthcare has ballooned to such a great extent that funds are being drained from education, from the environment, from housing, and from law enforcement. In fact, the only area in which funding is going up dramatically is healthcare, and we're now at close 45% of the provincial budget being spent on healthcare. It's headed, if we don't change, to get up to 100% in the next 15 years. Well, clearly something's got to give before then. So I think that as a society we have to start making choices, and maybe education is even more important than certainly it's more important to educate a child than it is to treat an adult for a sore elbow that doesn't allow him to play tennis. And I think society hasn't made those choices so far.
Yeah, I'm not sure what choices we've made within the healthcare system. I mean, again, the promises are so extensive, with an aging population, for unlimited access, apparently, to massively changing technologies and therapies on a closed envelope.
I think one of the most interesting issues in autonomy and responsibility is that not all very elderly people want everything that we offer them. Very few, if any, politicians are or will be willing to discuss this. Sven Robinson was one of the few who was. And yet I've had many patients who actually do not wish to be treated, and in fact would like their life to end much faster if possible. That's not presently allowed to them legally or ethically in Canada.
Isn't that another example, though, where the individual's been taken out of the healthcare loop?
Precisely. And many people feel very offended by that personally, and as do their families, and feel that politicians have, and elected people and media have circumscribed and limited the debate in a way that is going on behind the scenes in every living room, in every sick room in Canada, and yet we ignore. And
certainly a debate we've avoided every other place, though. I mean, you know, the longevity issues, and do you keep people, you know, is our goal to keep people alive to the last possible second, regardless of quality of life?
Most real people, at some point in their life, do deal with the fact that human beings are not immortal.
Yes. We've had a very hard time knowing how to have these complex ethical debates about all kinds of issues, and I think because we've failed to have the discussions, we have these paradoxes in the healthcare system where we have easy access to certain highly expensive, not terribly efficacious remedies, with very little access to some of the other things that people do feel would make a difference in their quality of life. And we don't have good ways of having those conversations.
But I would like to point out that there are also thousands of people across this country now who are in the 70s and 80s who are suffering and in pain, and the healthcare system is denying them simple remedies to deal with that pain, such as joint replacement patients, and their quality of life would be improved. They would live a more productive life, and I think that the elderly population also needs to be looked after. But the problem hitting society now is this age group costs a lot of money to look after, and there are going to be, because of demographics, fewer and fewer tax-paying workers providing the funds to look after elderly people in the next 15 to 20 years.
Yeah, when you look at those numbers about the proportion of the population that are in that senior category and then the amount of healthcare resources, and you extend that out, that's what we talk about, this aging
And it's a crucial reason for increasing societal responsibility on all Canadians. If we're going to have resources to deal with the people who inevitably have problems, which are not their own responsibility, we must start reducing some of those problems that can be avoided.
Well, I think, as I say, this is a topic that isn't addressed near often enough when we look at the healthcare reform debate. I want to thank you for advancing it with us today, Dr. Tom Perry, Dr. Sally Thorne, and Dr. Brian Day.
Thank you, Michael.
Please address your comments to health_care@telus.net.